Thank you, Miguel, for those very kind words. And I want to especially thank Imad and as well as Vladimir and the entire WFNS Neuroanatomy Committee for putting on these very, very educational and important webinars. I think, you know, they're very important at any time, but particularly in this terrible pandemic that we are doing. These are very, very useful for young neurosurgeons that can see these from all over the world. They don't have to travel thousands of miles. So thank you again, Imad and Vladimir. And also to the other speakers, all of my friends, excellent presentations. So my talk this morning is on the management of recurrent and giant adenomas. Now, there's a number of controversy and challenges in pituitary adenomas. Many of these have been addressed today. The whole issue of diagnostic controversy, the predictive markers, the management of cavernous sinus that we just saw now, the role of radiotherapy, indication for craniotomy, but also very challenging are the management of, the management of recurrent and also the management of giant adenomas. So this is a patient that I operated on back in 1990, 30 years ago, with a pituitary adenoma, microsurgical transsphenoidal surgery with this rather large adenoma presenting with vision. This patient, sorry. I don't know what's happening with my thing here. 30 years later, as you can see, no evidence of recurrence of normal pituitary function. Now, I think all of us would love if all of our patients were like this. But unfortunately, we know this is not the situation in the majority of cases. And in fact, this is the one that's more common. Operated on very similarly, 1993 with a microscopic approach, had a recurrence after 4 years, did a repeat microscopic transsphenoidal. He then progressed. We watched him for 10 years, and then he had disease progression, and we did an endoscopic approach. I started with my endoscopic series. And then again, 7 years later, further evidence of growth and vision worsened with repeat endoscopic resection. So 2 microscopic, 2 endoscopic, and then we watched him a little bit with the residual disease in the cavernous sinus and had further progression. So what do we do now for this patient? Well, we'll come to this later. So recurrent pituitary adenomas, unfortunately, are common. The incidence can be up to 50%, and those with cavernous sinus involvement at 10 years can be 80%. The peak time to recurrence is 1 to 5 years, but the time to recurrence can be extremely long, and other presenters have talked about this, the importance of long-term follow-up in pituitary patients, because they can have recurrences at a very delayed fashion. These are difficult management problems. We know that repeat surgery is always challenging and not as easy to perform as a primary surgery, and we know that they're associated with increased morbidity and decreased favorable outcomes. And if you look in the literature, interesting, there's no major international consensus on the optimal management of residual recurrent pituitary adenomas. In other words, the role and timing of repeat surgery. What about radiation, medical therapy? But we do know that the management often requires a multidisciplinary approach, that surgery alone is often not the answer. So the risk factors for recurrences, of course, we all know this. Incomplete tumor resection at the initial surgery. There's a tumor biology and invasiveness is important, particularly infiltration of the adjacent structures, cavernous sinus, carotid artery. And very important is the experience of the surgeon, as we know now. And very important is the duration of follow-up. So what are the treatment options? We all know this. Of course, we can watch these, wait and see. We can do repeat surgery. We can do repeat surgery with radiation. Radiation alone has been used for recurrences, medical therapy, chemotherapy, and combination therapy. Now, our series approaches almost 2,000 cases of endoscopic resection of pituitary adenomas. And questions we wanted to answer early on when we did this was to look at could the endoscopic technique reduce the incidence of recurrence and improve our ability to deal with recurrent adenomas. So early on in our experience, we reported this back in oral neurosurgery in 2012. We looked at a very small series of about 39 patients that had a previous microscopic. You can see the demographics here, non-functioning and functioning, but also look here that 43% had already frank cavernous sinus invasion. So this is a typical patient that you see here. Not sure. Here we go. The beauty of the endoscopic, and this has been emphasized, is the wide panoramic view that you get. That in this patient, you can see the lesion was adjacent to the cavernous sinus on the left side, and this allows us. Here's a beautiful, hardy type of pituitary microadenoma that you can see very nicely. That we can then take off, and I won't bore you with the video all the way. But here we are taking it off the medial wall of the cavernous sinus. All the way here, and then after the removal of the tumor, you can see here, beautiful view. You know that you've now got a nice total removal of this tumor, carotid artery, and this patient post-operatively, you see, had urinary free cortisol over normal. 7 year, he remains in remission. And just a comment about cure in functioning tumors. We do not talk about cures in acromegaly or Cushing. We talk about remission because we know that these can recur at 5-10 years. This is a patient with the acromegaly, persistent acromegaly after microsurgical. And the problem here, of course, was this conchal type of sphenoid, bone all the way around. And the endoscopic approach, again, allowed us to drill down widely to allow us to expose the cellular area. And then after, again, the removal, you can see, again, a nice removal. Again, the medial wall of cavernous sinus wall cleaned. And this patient is post-op 5 years in remission. Finally, this patient is a 53-year-old male, had a microscopic with partial removal. And the problem here, of course, was these kissing carotid. Look at you have about 3 or 4 millimeters that you can deal with here. But the advantage of the endoscopic approach is that it can give us an ability to do a little bit of an expanded transtubercular approach that allows us to go above. And again, very quickly, you get a very nice exposure shown here. And this is basically, as we're drilling off, these are the carotid arteries here. And this is us with the Doppler ultrasound identifying these. And then we basically go above and do a little bit of planar exposure to allow us to get a decompression of this patient whose vision was the major issue. And just go quickly there, reconstruction. So this patient, if you can see, improved in his vision. We did not get the total removal, as you can see here. And our plan here is to observe. So this is the results of our series. As you can see, the gross total movement rates are 54, not high, but these are recurrent tumors, and 43%, as you recall, had frank cavernous sinus invasion. The gross total movement rates were very satisfying in the non-functioning adenoma, 86%, as long as there was no cavernous sinus invasion. Once a tumor goes invasive to the cavernous sinus, I must say I have the philosophy opinion that it's not really possible to get a gross total removal. In functioning adenomas, you can see Cushing's disease, 75% remission, and growth hormone, 44% remission. Now, you can't say very much with a series of 39 patients or so, but our feeling was, at least looking at the literature, that the overall results of these were better than in most reported series of recurrent microscopic surgery. Of course, the cavernous sinus invasion was the major predictor of outcome. And this is Cabianca's and Cavallo's group in Naples. Very similar results. Growth total resection was 62%, 59% from a previous, and 74% it was a previous microscopic approach. This is a systemic review, and of course we always have to be careful about systemic reviews. Sometimes they cannot be, they can be biased to one or the other, but 15 studies, the remission rates, these are non-functioning adenomas. The remission rates for non-functioning was 76%, 44% in growth hormone, and Cushing 55%. This is our series that I want to just spend a little time on, because this is just recently published in World Neurosurgery in October. And what we wanted to look at was long-term follow-up, because we knew that these patients recur. So a 2-year, 4-year, 5-year follow-up is not adequate to really find out this injury. So we wanted to follow them long-term, 10 years, and you can see 2005, 2015, 269 patients. You can see the demographics here. These are largest tumors, 2.5 centimeter medium, and the results that you can see here of the pathology. What are results? Well, again, not terribly exciting in the sense only 54% did we feel we were able to get a gross toe removal, a true gross toe removal. And again, you have to understand that the cavernous sinus invasion was present in almost 50% of patients. Now, the gross toe removal rate varied according to cavernous sinus involvement. Those with cavernous sinus involvement, we were only able to achieve 27%, and I think that's optimistic, versus 72%. Also, we know that recurrent surgery carries more complications. So hypopituitarism, one or more hormones, 11% after the first surgery, but 21% after the second surgery. What did we do with what about the number of recurrences? The overall recurrence rate was about 21%. But the recurrence rate was 22% at 5 years, but when you follow them to 10 years, it doubled. The median time to recurrence was 10 years for patients without cavernous sinus involvement and 6 years with those with cavernous sinus involvement. A third were symptomatic, usually vision, but 2/3 were asymptomatic. The risk factor for recurrence, we all know, these are things that we all know. Size, of course, is very important. Cavernous sinus invasion, anterior skull base extension, residual tumor after previous surgery, all significantly associated with recurrence. In a multivariate analysis, age, tumor height, cavernous sinus involvement, and residual tumor, again, associated. Interestingly, and this surprised us a little bit, in general, tumor pathology was not found to be a significant factor, although the silent corticotroph subtype adenoma had a higher tendency for recurrence. How did we manage these? Well, 52% of patients required a second surgery, primarily because of vision or to present visual complication in a lesion that was continually growing. Here, the gross total rates that you see very poor. Only 28% did we feel we could get a total gross total removal. 15 patients underwent radiation, 9 gamma knife, 6 fractionated, 10 after the first recurrence and 5 after the second, with a relatively good tumor control rate. So let's go back to that patient that I operated on. 2 microscopic, 2 endoscopic, with now residual in the cavernous sinus. Well, in my mind, and I may be wrong, but I do not think that surgery has a really is a real cure, at least solution for this patient. And so we recommended radiation therapy, IMRT radiation, and he now 5 years stable disease. So this brings us to the whole issue of radiation pituitary adenomas. We know that they have a role to play, no question about that. A variety of modalities have been used, as you can see here. What does the literature suggest? Well, in terms of remission rates in functioning acromegaly, roughly 40 to 60%, Cushing's 40 to 50%, but in non-functioning, you see very high control rates at 5 years, 88% control. This is a literature review by Jay Lawfer and his group looking at evidence synthesis that there is a high success rate in controlling tumor growth up to 80 to 97% in most series, regardless of the radiation technique used or the adenoma subtype. Hypopituitarism, as we all know, is an expected result of radiation therapy, but overall other treatment-related adverse effects were relatively low. And it's a series with a meta-analysis of non-functioning adenoma looking at 2,000 cases. The 5-year, they use also stereotactic as well as a hypofractionated stereotactic radiosurgery. 5-year low control rates with stereotactic 94% at 5 years, 97% with hypofractionated. 10-year, of course, it drops a little bit to 83%. There's no question that stereotactic radiation is an effective and safe treatment for patients with non-functioning adenomas, recurrent adenomas where surgery is not feasible. Now, I don't have time because of just the amount I have, but we all know that the recurrent tumors, there is a medical management. These have all been used for different functioning tumors, but we also know that these are used now, medical management for non-functioning. So our endocrinologists will place patients on folate antagonist, including dopamine agonists for recurrent pituitary and non-functioning pituitary adenomas. So this is a summary of current guidelines. I said there weren't many guidelines, but this is from the Congress of Urological Surgeons and the European Society of Endocrinology. They recommend that a dedicated pituitary surgeon's opinion be sought on repeat surgery prior to proceeding with adjuvant therapy. So now you have to be an expert that could say, no, I can reoperate on this as opposed to going immediately to radiation. Patients should be managed in a setting of a multidisciplinary team. Repeat resection is recommended for symptomatic recurrent or residual tumors, and that stereotactic surgery is recommended for residual tumors. There's still controversy. What do you do? Do you do it immediately after the surgery when you know you have a residual, or do you wait for a recurrence? There's a controversy on that. So getting now to the management of giant pituitary adenomas. Again, the incidence is roughly 5 to 14%. We know these are difficult management problems. They have increased incidence of neurological endocrine dysfunction. They have capacity for aggressive local growth. They're surgically challenging. The growth movement rates are usually low, often less than 50%, with increased treatment morbidity with increased recurrence rates. And again, the overall treatment outcomes are often not as good as in the smaller lesions. And again, the optimal management is really not clearly defined. Again, the same options for giant as you have for recurrent tumors. And this is, I just want to show this patient is a 58-year-old patient, very briefly, with this tumor that we did using an endoscopic approach. And this, just to show you very quickly, we do a middle turbinectomy on these giant tumors. I'm very liberal with the middle turbinectomies, but for these giant tumors for sure. And then the key is this nasal septovascularized flap that is very important in these giant tumors, that sometimes the CSF leak rates are a little higher. And then basically the key is, like all of this, to get this nice wide sphenoidotomy carried out. And then coming here, we see removing the thinned out bone. And then the key is, as noted, I think from Ed Laws, you have to do a wide exposure from medial wall of cavernous sinus to medial wall of cavernous sinus, from the superior to cavernous sinus to inferior cavernous sinus. And then the resection is done in layered system. And if you can get this nice diaphragma to descend, all the way over here, sorry. Here's the patient's postoperative course on the first day. We do, I think some say we do a postoperative scan on the first day post-op to look at any bleeding and so forth that we can compare. We don't do MRI scans. I agree with Dr. Laws that it's useless up until 3 months. But this patient, as you can see, 2 years, nice resection. This is a patient, another patient, 74-year-old gentleman, again with this large tumor. And again, just to very quickly go through. Again, the wide exposure, and just to show our technique for these and out to the key is to do a layered approach. Don't go immediately medial to go up, because you get the diaphragma that descends. I go inferiorly, then go up the medial wall of cavernous sinuses on each side, and then sometimes you can find this this plane that allows us to do an extracapsular. Now, in giant adenoma, it's not very common, but occasionally, even in the giant, you can do an extracapsular removal. This patient, you see, had improvement in his vision. And the other thing I would just want to say, you'll see here the postoperative day scan. It's nice to see this. This patient, however, had improved vision immediately postoperatively. So do not panic and say, he's got this, he should rush back. If the patient's vision is better or stable, this is we see this sometimes, and within 6 months, as you see, of the MRI scan, but within a week we did it, that hemorrhage has reabsorbed, and you can see the 6 months here, a nice resection. Finally, this patient here, as you can see, with this large tumor going anteriorly, well, I think before endoscopic surgery and expanded approaches, you might say this would need a craniotomy. Well, now with our experience with the expanded approaches that you can see here, using a transtubercular transplant, we can get a very nice resection of these large tumors. And just again, take you quickly over here as we go up. And then this is our transplanter approach. Here's the dura. We're cutting the dura here, and then basically you deal with it with just like you would under the microscope. Bring the tumor down. You could debulk it more until ultimately we have gone above the tumor, and you can see a nice view of the chiasm here and the tumor brought down, and the pituitary, the pituitary stalk here. This patient is the post-op MRI scan, and he's now 8 years and remains recurrence-free. Finally, this patient here, 34-year-old patient with an M1, headaches with this tumor, had a prolactin 20, but you know this is not a prolactinoma because it should be up in the thousands for this. And the prolactin was normalized, slight improvement in vision, 6 months. You can see residual disease. What now? So we did a expanded transphenodal approach for this. As you can see, improvement in his vision. This was a silent subtype. These are aggressive tumors and with significant residual. What do you do here? Well, to me, with a significant residual, with an aggressive tumor, I think observation is not the way to go. And here we would go immediately to radiation, fractionated stereotactic, 50 gray, 3 years with stable disease. And finally, this one here, long-standing visual, he presented to us virtually blind with this tumor here. What is the best approach? Craniotomy, endoscopic combined. Well, we elected to do at least an expanded. Postoperatively, you can see we did not get a good removal. He had a left hemiparesis, cognitive dysfunction, worsening his vision, virtually blind. What did we do? Obviously, we injured his thalamic perforators going posteriorly here. Was this the right approach? Was the right technique? We're now basically the patient's 1 year, stable here, but virtually blind. So there are limitations of the transphenodal endoscopic approach: large invasive tumors, lateral extension, multiple compartments, vascular encasement. And what do? What about this patient? Large tumor going up into the ventricle here. To me, this is a bit back. He had a previous transphenodal. This, I think, is a patient that requires an open approach. And we did an open approach. Interhemispheric transbasal is my favorite open approach for these. You can see the tumor, and we work basically in the lamina terminalis, the third ventricle, ultimately getting a nice removal that you can see here. This patient's 15 years with stable disease. And this patient here, obviously, going out lateral like this is not a good a patient for a pure transphenodal approach. And so I would not do, if I can do one procedure, that is good. To me, the open approach is the best procedure here. And again, here, this patient bifrontal tumor removal. After the tumor removal, and you can see the patient here, improvement, at least no change in the left eye, but improvement in the vision. So this is our series, was published back in 2014. Just very quickly to go through the definition, we use a volume base because we think it's a little bit sensitive than a linear base. We use 10 centimeters for defined as large or giant. Here's the parameters, the outcome. We want to look at extent of resection, visual changes, complications. 73 patients met the criteria. You can see here the
2 minutes, Fred, 2 minutes.
Pardon?
You have 2 minutes left.
Thank you for the reminder. The presentation, you can see the majority and is visual compromise, and the average tumor size you can see quite large, 18 centimeters. This is the pathology. I don't have time. We use a pure endoscopic approach for all of these. The cranial ones that I showed you was before this series, and then we use an expanded approach in 5% of the patients. So what are the gross total removal rates? As you can see, very low, 24% did we feel that we really had gotten a gross total removal rates. If you want to bring in near total, which I don't know, people use these, well, gross total is only 41%. What I wanted to look at as a predictor of extent of resection was maximal diameter and volume, of course. Hemorrhagic component of the tumor. Once you have a hemorrhagic component that then has fibrous thing, it's very difficult to remove these tumors. And of course, invasion, highest NOPS grade is very important, and posterior and lateral extension. What we did not find significant of interest was that the pre-op visual acuity, prior surgery, which surprised me, or prior radiation did not seem to be a significant parameter, and even biological tumor characteristic, the cell type, the MIB was not a significant factor. Is our complication rate? The improvement in vision was a 73%. Interesting, even these large ones, we had 15% that did not have significant visual. CSF leak rates was about 10%. It's a series in the literature. I don't have time to go through these. Looking at the approaches, whether transsphenoidal or transcranial, again, really low total gross removal rates. So this is the conclusions that I have, is that endoscopic approaches can obtain an extent of resection equal or higher to transcranial technique for giant midline located tumors. Endoscopic approaches are safer and more effective in alleviating symptoms. Transcranial approaches are favored for tumors extending laterally to the midline, and that radiation therapy has a definite role to play in controlling residual tumor and recurrences. In conclusion, recurrent and large giant pituitary adenomas remain a significant surgical challenge regardless of the approach or technique. And however, recurrent and giant pituitary adenomas often require a multimodality approach with adjuvant radiation and or medical therapy to effect long-term control. So what we say, the evaluation and management of patients with recurrent and giant pituitary adenomas require the active participation of an experienced pituitary surgeon, as well as an equally experienced multidisciplinary team of endocrinologists, radiation oncologists, medical oncologists, and pituitary neuropathologists. So thank you very much for your attention.
Thank you very much, Professor Gentili, for this wonderful presentation, just showing your expertise and also the judicious use of all the tools for the control of such a complex tumor. I like to make some comment. I like very much your slide regarding the factors for recurrency, and it is assumed that positive immunochemistry for any of the hormones, although not being an hormone producer tumor, is associated with higher rate of recurrency. It wasn't the case in your series. Is that right, Fred?
What we found that the hormonal type was not a significant factor. That's correct, which was a little surprising to me, as I said, and also the fact that the MIB and these other factors were not. I don't know if that's a relationship to the numbers, that they're not big enough or not, but we know that, for sure with regard to remission, I looked at growth hormone rates. Remission in giant functioning tumors is very, very, very low.
Okay, thank you. I have another question. I think it's something of real interest for the youngest colleagues in the audience. What is your policy regarding the situation of invasion of cavernous sinus? Yeah. Are you aggressive as a policy or only in certain cases?
Yeah, so Miguel, absolutely. And I think this is important because we have the situations where you have the people very aggressive, going into the cavernous sinus, mobilizing the carotid and so forth. Now, I've never been a proponent, going back to my open skull base, of a proponent of radical cavernous sinus surgery. I have not. And in the pituitaries, if I have a tumor that leads me there, of course I'm going to follow it. It's already destroyed the medial wall of cavernous sinus. You go in and they're nice cyclable. You'd be silly not to follow it. But to go through, to remove the medial wall of cavernous sinus, I do not do that. It's my philosophy that the likelihood of getting a gross toe removal, and what are you decompressing there? You're not decompressing the optic nerves. If the patient has a third nerve palsy or a sixth nerve palsy, by just decompressing the medial aspect, they'll improve. Just on that. So to answer your question, after a lot of that, I'm not a fan of cavernous sinus surgery.
Thank you. This is a very interesting comment, because sometimes when seeing videos regarding resection at the cavernous sinus, I very seldom see a cavernous sinus bleeding. Maybe all the bleeding cavernous sinus are here in Malaga. I don't know.
That's correct. That's correct.
Okay. Thank you very much. Is there any question? Imad, my friend.
May I ask? Rudolf?
Professor Falbush.
Yeah.
Please go ahead.
Fred, how many times would you reoperate a recurrent tumor? Does it depend on the distance, how long is recurrent free? Let us say, if the tumor reappears after 10 years, would you do it 2 times, 3 times? Or on what criteria do rely reoperations?
Yeah. Thank you, Rudy. That's a very good question because, you know, as I say, there's no consensus there. When should you say, okay, like I showed the other one, after 4 operations, I figured, okay, that's enough. I don't want to do a 5th operation. I've come around to looking at more, what can I do in this patient? And can I get a growth tool removal? Because if I feel that, you know, that there's a recurrence, that I look at it and I say anatomic, I think I can, you know, help the patient by decompressing, but also get a growth tool removal, I will do that. You know, first time, second time, maybe even 3rd time. The other very important thing, Rudy, I look at where it is. And I just told you about cavernous sinus. I'm not a keen that. So if I do one surgery and it has a recurrence in the cavernous sinus, I go for radiation. There's no use doing another you know, operation when I know I'm not going to get a growth tool removal. So the location is very important. But if it's still midline and for whatever reason it keeps going, that you can do a good safe operation to decompress critical structures, I can still do that. But when I look at, you know, 2 to 3, after 2 to 3 surgeries, if I haven't, and I'm the one who did it, if I haven't been able to get a growth tool removal and a remission in that patient, I'm not going to do it the 3rd time or the 4th time. So I become less and less, you know, aggressive with multiple surgeries and use radiation, because as much as I know as surgeons, we somehow don't like radiation, but radiation is a viable option in pituitary tumors with good results.
Okay, thank you.
Any other question?
Nadia.
Yeah, please. Well, I have a question in the same way. Did you have some cases when we operate first, you have a reduced surgery, for example, and go after reduced surgery? Did you have some case like that?
To go immediately? I didn't understand, Nadia. You mean after surgery?
When you have to repeat surgery after the first surgery and reduced surgery.
After the first surgery, it's rare, you know, that I would do radiation. I mean, you know, if it's as I saw in the other one that had significant residual, that you might do it. But generally, I will observe the patient. If the lesion is in the cavernous sinus, we know that some of these are indolent; they will remain there and not go. So I like to see that there is evidence of progression, and then I will consider a radiation. But that is a good, and it's controversy, as I said. Generally, in U.S. and Ed will maybe correct me, that the general feeling is that the ones that use radiation will generally go fairly quickly to radiation if they see that there's residual. Whereas in Europe, generally they will wait and see that there's progression and then consider radiation.
Okay, thank you.
I think this is a very important point. Once you see there is some residual tumor, maybe cavernous sinus or wherever else, how long do you wait, or do we wait until radiation therapy? I try to, delay in as much as possible radiation therapy, mainly if the pituitary gland could be in the radiation field, because the rate of hypopituitarism is no less than 60% at 5 years, not less than 80% at 10 years. So my policy is just trying to delay in as much as possible the indication for radiation in this remaining lesion. I don't know your policy.
So the issue there, Miguel, is that the radiation oncologists, and they've done some studies, and I don't know, how valid they are. They suggest to them that at least is that if you delay it, the results are not as good as if you do it up front. Now, I don't know if that's a way of getting you to do the radiation. I don't know. In the literature suggests some of these studies that, that delaying it and then just doing it when they start, that is not as a good outcome, but still good, but not as good as if you did it up front. But I don't have a complete answer to that.
Thank you. Thank you very much, Fred. So, well, I think we have to move on, and